So once again, thank you for having me. It's a true pleasure to be here. The quality of the meeting is amazing. I've been learning a lot, and I think it's a unique meeting in the quality that stands out among other meetings in the region. So the intolerant patient, a patient that is not tolerating medical therapy, can be a headache, not just to you, but a headache for himself and a headache for his family. We have to make to distinguish between an incompliant patient, a patient that is not taking his medications, and who you can influence directly or indirectly to put some more effort into taking his medications, and an intolerant patient that is unable to take his medications because they're giving him too many complications or side effects. Obviously, a lot of patients that are not complying are intolerant. They are not tolerating the medications, so they are not taking it. So there is an interplay between those two different types of entities when we speak about medications. Now, why? Why are patients being intolerant to medications? First of all, we know that ocular surface disease is an entity, a pathology that happens to elderly patients. Some of those elderly patients can develop glaucomas. Patients with pseudo-exfoliation syndrome or glaucoma have inherently a problem of ocular surface disease. So we take a group of patients that are prone to ocular surface disease or have already ocular surface disease, and then we start bombarding their eyes with medications, with different molecules, and those molecules, unfortunately, can push them over the cliff and produce clinically significant ocular surface disease with all its symptoms and signs that cannot be well tolerated by the patient on the long term. Some patients will not be able to tolerate specific local side effects. I remember a general from the Turkish army that came to me that was put on a prostaglandin on one eye, and his eyelashes were quite long on one eye compared to the other. I mean, from his point of view, he does not accept and does not tolerate the medications that we gave him. Some patients are not tolerating medications because of their systemic side effects. Now, the systemic side effects that we know of related to arrhythmias, to bradycardias, to bronchial asthma, this is what we really concentrate upon. But we forget two very severe systemic side effects that we often forget, actually. When beta blockers were introduced in the UK many years ago, there was a landmark study that showed an increase of the fracture of the neck of the femur among elderly patients taking beta blocker medication. So elderly patients would fall if in some instances having taken beta blockers. There are also patients who are prone to depression, and we know that some beta blockers can increase the levels of depression for those patients. So all those could be ways where intolerance would happen. Now, patients who can't sustain medications and are intolerant, some of them are intolerant to some medications and others are intolerant to all medications. So let's consider first those who are intolerant to some medications. Well, the first question that we should ask ourselves, are we giving enough or are we giving too much medications? In many cases, we overprescribe. In many cases, we're giving patients 4 molecules in 4 bottles, each with its own preservative, and that is too much. Do we need all that? And again, do we need to increase medical therapy or not? Always depends on the potential for progression. Is there progression that you can see over those decades with the same dress and the same smile? Well, some people can catch a few changes, but then some changes are more obvious than others. So if progression is happening and that merits a certain treatment, this is one thing, but if we are over-treating with no progression, this is a different thing. Not every single glaucoma patient needs a pressure of 10. A lot of patients can sustain a very good visual field that is stable over decades with a pressure that is much higher than that. But now the question is, if some patients are not happy with some medications, what can we do? I mean, there are obvious answers. Switch. So you can switch within classes. You can switch within the same class. You can go from one prostaglandin to another. And whatever number of studies that comes to you courtesy of the of pharmaceutical industry, there always the question of these are statistical analysis of a big number of patients, but your specific patient can do better with X versus Y versus, it is not one hat fits all. If some medication is known to be more allergic, yes, the probability is, but some patients do much better on those. Now you can switch between classes, so you can go from a prostaglandin to beta blocker. You can fix the combinations. Instead of giving 2 molecules in 2 bottles, give them both in 1 bottle, preservative-free. Of course, the preservative-free revolution has been knocking on our doors for the last 10 years or so, and rightfully so. We have been using benzalkonium chloride. Benzalkonium chloride is a detergent. There's no real argument for us to continue to need to use benzalkonium chloride. All the preserved medications on the long run is affecting the eye in a noxious way, and if this patient is headed for glaucoma surgery one day, the potential for success is diminished if he has been taking benzalkonium chloride for a long period. I'm quoting from a landmark study from published in the Canadian Journal of Ophthalmology. But mind you, the industry has been putting a lot of pressure on us, saying avoid benzalkonium, which is not a wrong message, but the flip of the coin is it's not just the benzalkonium. The active molecule in itself can cause allergy and can cause toxicity. So it is not simply because we have removed the benzalkonium that we will live happily ever after. There's no holy grail here. Now, okay, so we go to preservative-free, and there's a lot of push onto the monodoses, and monodoses are not a terrible option, but they have also their side effects or their difficulties. Some of our patients are unable to use them. They have a tip that is very abrasive, so a lot of patients would come with erosions in their cornea, having touched their corneas with the tip of those devices. So they can be traumatic, and they're not also very ecological. In some societies, the number of plastic that you're throwing away with monodoses is not making our patients happy. There is a solution, the multi-dose preservative-free, and if I would prescribe something to my patient, I would go for a multi-dose preservative-free bottle. But you have to test yourself the bottle, because different companies provide different bottles, and you need to see how soft it is and if the patient is able to use it or not. So please test the bottle itself before prescribing it. Now, patients who are not tolerant to all medications, and there is a number of those patients, unfortunately. For those, you are left with 2 options: ignoring medications, so going in the direction of an ALT or an SLT. ALT or SLT doesn't really make a big difference. SLT is easier to use, but it is a device that is expensive, and you only use it for glaucoma, while if you get an ALT, it can also serve your retina specialist. 180 degrees versus 360 degrees. SLT is not revolutionary in the percentage of reduction of intraocular pressure that is going to happen. So please don't shoot yourself in the foot and go for a half treatment. Go for the full treatment and go for an early SLT. Don't think that you are going to get a patient that has not been getting good reduction after 3 molecules, and you will do an SLT and everything will change. SLT in my hands is really has a niche as a primary treatment if possible. And a lot of my patients now are opting for a trial with an SLT before we start medical therapy. Now then, if all that fails, or if the patient is really in an advanced state, and I do not have the flexibility to wait and see if the SLT will work or not, then I will opt for surgery. Which type of surgery? As you can see, there's a lot that is now available to us. We'll discuss that in the coming 2 lectures. But again, I remind you that cataract removal in itself can reduce intraocular pressure, and this is something that you should tap into if possible. Thank you very much for your attention.